clinicians here, and we all are interested in writing an article based on our clinical observation. So the most important part of writing our paper is like having a clear result and being able to forward a good or result-driven recommendation so that it can be used as an input to guide our clinical clinical practice or to be part of further evidence generation. So today we're going to see result-driven discussion and recommendation. This is simply how we define research. Research is a systematic collection, analysis, and interpretation of data to answer a certain question or solve a problem. So every research starts with a question or a problem, and we have to design a way to answer that problem. That means we write a proposal. And to implement the proposal, we need data, and we have to be able to collect our data systematically in a way that can make our life easier when we do data management and analysis, and in a way that's adherent to the acceptable ethical standards of the country and also internationally accepted standards. After we get that, we analyze our data. That means we get results. And after we get our plain results, we have to interpret them, contextualize them. We have to give them a meaning so that we can apply the results. So when we talk about discussion, conclusion, and recommendation, we're talking about interpreting our results and applying that into practice, identifying what we have found from this research and what can be applied to the current practice. So this is simply the definition of research. Since we're going to talk about result-driven discussion and recommendation, let's say a few things about results. So every research starts with a question. So based on our research question, our objective will be defined within that context. And based on our objective, we have to select the proper analysis methods for both the descriptive and the inferential. And based on the analysis, we get our result. And this result will define our discussion, conclusion, and recommendation. So this is very important. Whenever you write an article, make sure that everything has a flow from the very beginning to the end. If you change your research question, everything else is going to be changed. So you have to make sure that everything is in line with each other. So our result is objective driven. And the rest of making meaning out of our results, the process of making meaning out of results, which is our discussion, conclusion, and recommendations, are also result driven, which is indirectly objective driven. So maybe to give you an example, let's say we have a research question that is interested in studying the prevalence of MI among hypertensive patients. So this is our question. When you change it into an objective, you can say that we want to determine the prevalence of MI among hypertensive patients. And you can make it smart by adding the location and the time period and other factors. After that, you have to be able to pick the proper analysis method. So to find the prevalence, what we do is simply we calculate proportion. That means we can count the total number of MI cases, and we divide them by the total number of study participants, and we multiply it with 100%, and we will get our prevalence. So we are going to use proportion or prevalence estimation as an analysis method. And let's say we get a result of 6%. So discussion means, what does this 6% mean? We have to attach a meaning to this 6%. We're not just interested in the number, rather we want to understand what this 6% means in the context of a number of factors. So this is what the process of arriving at your result is based on your research question. As you remember, or you can go back and refer, there are like 4 webinar series on data analysis for each level and step. To give you just some idea, there are 3 levels of data analysis. The first one is after you obtain your data, there are 3 things that you can do. So the first one is describing your data. That means characterizing your study population. And when you characterize your study population, you have to consider all variables. That means both the exposure and the outcome. So you have to be able to give like description of the study participants in terms of their age, their gender, their place of residence, their symptom, their clinical presentation, their laboratory values, many other factors, and their outcome, which could be it could be whether they're like recovered or died, or it could be their length of stay, or it could be whether they have developed complication or not. So everything, every variable on which we collect data has to be described in this section. And this is not an option. This should be presented for each and every type of research in both qualitative and quantitative. This is universal data analysis step. Every research has to start with describing the data so that we can have a context of what kind of population was studied, so that the rest of the result can give meaning based on that population characteristic. So for this, we use descriptive analysis methods, which again, you can go back and refer. And the second part of analysis that we can do is comparative analysis or comparing groups. So comparing groups is sometimes we might be interested in comparing a group of study population based on their particular characteristics of interest. It could be based on their outcome or exposure. So that the whole point of comparing groups is, especially when we're doing analytic comparative research designs, when we're using that kind of design like comparative cross-sectional design, case control studies, cohort studies, or interventional studies, we have 2 or more groups. So in that case, we want to make sure that the groups are fairly comparable and they can be tested. So to assert to make sure that these groups are comparable, we have to run some statistics and see if there's a significant difference in terms of their age, their gender, or other clinical parameters. So comparing groups is not something that we do all the time, but when we have analytic studies, we can do that. For this, we use inferential statistical methods like chi-square, ANOVA, t-test, and like correlation and other non-parametric tests, which you can also access from the previous webinars. So the last level of analysis that we can do is building relationship, or identifying if some exposure variables are responsible for the development of the outcome under study. So this is the part where we're mostly interested as clinicians, because what we want to know is when our patient presents with something, we want to know what caused this problem. So this is a very critical step in analysis, but we can only do these types of analysis when we have analytic research designs. Otherwise, with descriptive designs, we can't do building relationship. And to get these types of relationship, we have to do inferential analysis, particularly regression analysis of different types: binary logistic regression, linear regression, and so many other types of regression models. So don't forget that there are 3 steps of data analysis. The first one is describing your data, which is mandatory for every type of research. And depending on the nature of research, we can do comparative analysis and regression analysis so that we can answer our research question. So what does discussion mean? Simply, discussion means giving meaning for our result. Our results are just simply numbers, and that number has to be contextualized so that we can have a better understanding of that result, so that we can intervene accordingly. So what are the contexts in which we can give meaning to our result? In the previous example, we said there are the prevalence of MI was like 6%. So what does it mean? How can we discuss it? How can we give it meaning? The first one is we can compare it with the established scientific facts that we know so far, like for the already known facts like evidence. For example, for some surgical procedure, there might be some known risk of complication from some surgical procedure. And if we conduct a study and we discover that the rate of complication is more than expected, then that has meaning. I mean, we can comfortably say that a lot of people are complicating from the surgery than expected, so we should do something. So the first thing that should come to your mind is when we're discussing a result is, are there established facts or evidences with regard to this number or associated factor? So that the first thing that we should compare with is some established facts. The second is in terms of policy. For example, if we're studying about vaccine coverage for a given condition, let's say COVID-19, and if the national targets or the WHO target is to a coverage of like 80 to 90%, so that we can prevent further infection spread and we can protect vulnerable population. But if we conduct a study and we learn that only 30% of the population is vaccinated, then this is a small number. So when we discuss, we're going to say that given the current policy, given the current national and international targets, the vaccine coverage in our country is small, and it could be because of this factor. So when we're going to compare our results, we have to contextualize them in terms of the current policy as well, whenever there is. And the other is we have to compare it with other studies. This is something actually that you are going to see in many research as a preferred mode of discussing our results, but it should not be given priority, because what the results we obtain could be completely different from what's already known. We shouldn't frustrate as long as our procedures are correct, as long as our data is credible, and as long as we follow everything properly and we arrive at a credible results, then we should feel comfortable. That could be the beginning for us to question what's already known. We should not expect our result to align with every other research that was studied in the past. Well, if it aligns with other research that we already know, well, it can be an input for evidence as part of reviews. As part of reviews, meta-analysis, systematic reviews, or umbrella reviews are based on the studies, single studies conducted so far. So if our study matches the other studies that are conducted so far, it can be used as a part of evidence, which is good. Well, we can say that, okay, this thing is, what we found is also in line with what's studied so far. So it means there is a chance that this thing is fact, or there's a chance that there is a cause-effect relationship between these factors. But when we don't get that kind of result, we shouldn't frustrate, because in the past, we know that there are a number of studies which demonstrated a good or beneficial effect on some drugs, but after some years, those results were like declared to be like wrong or not efficient, and some drugs were banned from the market. So don't worry, as long as your research is properly conducted, we should not expect it to align with every other research result that we know so far. So the most important part of discussing our results should rely on the above two, and actually we can put it like this: more emphasis should be given for what's known so far, established fact, and the current policy. And after that, you can compare it with other research. But whenever you do these three things, there is one important factor that we should consider, which is the population characteristics. I mean, the number, for example, 6% MI, let's say what we expect from MI from the total hypertensive patients from what we know so far is, let's say, 2%, and what we get 6%. Before we decide that this number is very high and we should do something about it, the first thing we should see is the characteristics of the study population, because if the study population included had like majority of them had like other additional risk factors, if they were old, and if they had other factors that could make them be more vulnerable for MI, then it should not be alarming, because this number is based on the studied population characteristics. So first we have to see if the study population characteristics is something that we expect considering the general population. So whenever you discuss your results in the context of these three things, always consider the population characteristics. We will see an article, so it might make more sense then. So what are the things that we can discuss? It should be based on our main results. So I want you to tell me, you can drop it on the chat box. So let's say we have conducted study, and we have put every result, like starting from characterizing the study population up to building relationships. So which results do you prefer to discuss? Let's see here. So for this example, we have determined the prevalence of MI, and we have identified significantly associated factors. And this is the result. So from the characteristics of the study population, we can see that among the 560 participants, 252 were males, 314 were from region X, more than half were adherent to medication, blah, blah. This is how you describe your study population. The second thing that you should do is you should measure the outcome of the study. Even if it's part of characterizing the study population, it's worth mentioning separately. So we usually present the outcome description separately so that we can give more emphasis and see it very well. And as we discussed last time, we have to present the results with upper and lower boundaries using 95% confidence interval or the other proper measurements. So let's say we have found a prevalence of 6%. And the third thing that we can do is we can compare groups. If it is a case control or cohort study, we can compare between the cases and the controls, or the exposed and non-exposed groups for cohort and RCT studies. Finally, we build relationship. We try to see what are the significant factors that affect the development of MI among hypertensive patients. So in this case, we can get different results. Some of the results can show positive relationship, the others negative, or instead of negative, no relationship. So let's say from our regression results, we have found that old age, being diabetic, and poor diagnostic skill of the clinician leads to a higher prevalence of MI among hypertensive patients. So this is, let's say briefly, the outline of our results. So which results do you want to discuss? Which results are worth discussing? Please let me give you 30 seconds and drop your answers on the chat box. Anyone? I mean, we have 4 groups of results. The first one is we have characterized our study population, and then we have presented the magnitude of the problem. We wrote that like MI 6%, prevalence of MI 6%. We compare between groups. Let's say it was a case control study, and we have found that the cases and the controls are fairly comparable. There's no significant difference. So we're good to go to do further analysis. And on the regression analysis, we found that old age, being diabetic, and poor diagnostic skill of the clinician is associated with high risk of MI. And we have, for the rest of the variables, like it could be gender or other factors, we did not get any significant relationship. So which results do you want to discuss? Okay, measuring the outcome, great. Great, so we all can agree that the outcome should be discussed. Great, the factors like the age of the participants and being diabetic should be great. But you left out the third factor, great. This is very nice, right? So the results that should be discussed are like our main results. Our main results indirectly means what was our research question. Our research question was we want to determine the prevalence of MI, and we want to assess the associated factors. So from this results, our first objective is answered by this result, right? So we measured the outcome of the study and we found 6%. So we have to discuss this result, and then we want to assess or identify the significant factors associated with MI, and we have identified 3 factors. So our discussion should be based on these 3 associated factors and the 6% prevalence. Other than that, we're not interested in discussing about their detailed characteristics or the no relationship results, or the negative means, I'm sorry, it might mislead you. It's to mean that there is no relationship. So we're not interested in discussing the other things. One of the quality of research article is that is being precise. So that comes when we are focused while we're writing our manuscript. So in our discussion, we're supposed to discuss only the main results, which are based on our objective. So here we have to discuss the 6% confidence outcome and the 3 significantly associated factors, because that's what our end goal is by this research. So the other is what the structure of our discussion session. section, the first thing that we can do is, it's a common trend. You can also skip this part, but it's a common trend to present a summary of what was done, what was our objective, what the sample size studied, and sometimes we can add the rationale of the study, but we have to make sure that this should not be more than 3 or 4 sentences. And the other is, as we said above, we have to discuss the main results, and the flow of the discussion should be similar with the flow of the results section. As we said, the results section follows a presentation that starts from the descriptive result and then measures the outcome and then compares groups and then finally builds relationship or runs regression analysis. So our discussion should also have similar flow. It actually makes sense. We start with the magnitude of the problem is this much, and then the significant factors are this. Even when we present the significant results, if we started with age and DM and then skill of the physician, then our discussion should also follow the same pattern and starts with age, DM, and skill. This is like to make our result more presentable and easier for the audience to read and understand it. It's not to create any complication or anything, or it doesn't have any scientific relevance, rather to create a flow, a smooth flow of result presentation. So the last one is we have to avoid confidence intervals. Sometimes confidence intervals and p-values are not something that should be presented in our discussion section. For example, we can say that the odds of developing MI among patients with diabetes is like 3.25 times higher than those with no diabetes. But in our results section, we normally present the odds ratio result with 95% confidence interval and p-values. But in discussion, we're not expected to present these details. Rather, we can present the 3.5 times higher, and then we can explain what that result means. Otherwise, p-values and confidence intervals are not welcomed. Sometimes confidence interval for our outcome variable, for example, 6% prevalence of MI with 95% confidence interval can be presented. But for associated factors, we don't present that kind of 95% confidence interval or p-values because it's not necessary. Discussion has to bring something different than the result. It should not be a mere repetition of our result section. So the other thing is, when we're discussing, we have to further contextualize our results in terms of its strengths and limitation of our study. This is something that should come as the last paragraph of our discussion section. And what are the things that can be considered as a strength and limitation of our study? Let me give you 30 seconds. And what are the things that you think should be mentioned as strength or limitation of our study? Please drop your answer on the chat box. Okay. Okay, sample size, okay. Sampling, okay. I think it would be nice if you can explain it further. Applicability, sample size, sampling. Okay, what else? Sampling. Okay. Sampling, is it as a strength or as a limitation of our study? Generalizability, scope of the study, great, okay. The best thing we can do in any researches, okay, and in any researches to make sure that we have designed it in a way that's feasible and acceptable, so that the results that we can get can be the best of what we can get given the resources we have. So what to talk about, the first thing is, if it's a new study topic, for example, if it's a new study topic, if there is no prior study on similar area, should we take that as a strength or limitation of our study? So being a new study topic, is that our strength or limitation? So you're studying on something. Oh, great. Limitation and strength. Wow. Limitation and strength. Can somebody please speak? You can raise your hand and you can explain. We can make it more interactive. It's usually one-sided. Strength, both. Okay, great. Okay. Can you explain why it can be considered as a limitation of our study? Great, thank you. But we're talking about a new research topic, something that has never been studied. So is that a strength or a limitation? Great. HP, I wish. Okay. The common question that I normally receive from my students is that when they are working on something new and when they couldn't find literature, they insist on changing their study topic or study area overall because they think it's a limitation of a study. Because it's something good. What's the rationale? I mean, when you write your proposal, I'm sure you all wrote a rationale or a justification for your study, right? The justification of the study should be like, what's a good justification for a given study? What is it that you write as a justification of your study? I personally read the justification of a study as the first thing when I review an article, because justification is the place where you learn that what this research is going to add from what we already know. So if a research is not going to add something new, if we're going to research something that's already studied, then there is no place for our study. It's not relevant. So having a new research topic is always good. That's what a researcher should do. In fact, I mean, we're not supposed to repeat similar studies. Rather, we should bring some novel ideas and we should study something that has never been studied. The fact that there is no prior study might not give us a broad perspective of how we can approach our problem. That can be considered as not a limitation, but I mean, understanding what other researchers have done, yes, before can give us, okay, that's good. Yes, I'm reading the comments. Yes, if we have knowledge of what others have done in the past and what others have understood, we can take their, okay, somebody raised a hand, you can speak. Please unmute him and you can speak. It's okay, great.
Hello, everybody. Thanks so much. I think everyone can hear me.
Thank you. Please go ahead.
Thank you so much. Thank you so much. I think the question I didn't understand very well. I mean, I understand the question and another way. I mean, when you say when I say limitation, I thought when you try something new, every student or everyone who's new at this to do research, you feel like you don't have the literature review, you don't have the documents or that you can make that can help you to do research. That's why the person cannot get encouragement and the courage to do things. So we usually see as a limitation to do new research. But in another way, as you say, if you try to do new research or you talk about new topic, it will be strengthened in your mind. You know, it gives you power of to do something. It makes you, proud when you try to do something new. But that needs more experience to make previous study. You have to make previous study, as I think. Sorry, my English is not good, but I think you understand what I'm talking.
Thank you so much. Very well explained. It's very nice. Yes. It depends on how you try to see it. So, I mean, sometimes if we know that how other people have studied it, and if what we have planned is, let's say, case control study design, and if we learn that that approach is not good because probably the exposure is rare, and we have to change our study design into a cohort, or if we originally planned a cohort and if it's not a good idea because the outcome is rare, then we have to change it. It will give you a lot of perspective having a prior literature, but just because there is no prior research doesn't mean we can't conduct research, because all new research topics have to be conducted so that we can actually say that there are research, right? So we can be the first people to do those research, and it's usually taken as a strength of your study. Studying something new is, yes, thank you. You're seeing the chat box, right? I'm trying to read that as well. So it's seen as the strength of your study. That's what we're always trying to assure when somebody conducts a study. What we're going to say is that, no, this is well studied. You have to come up with some other new title. So coming up with a new study topic is always a good thing, and it should be cited as the strength of our study. The other thing is methodological perspectives. So from the methodological perspectives, what we can talk about as strength and limitations are our design, the period of observation that we have made, and the variables addressed. So in both, we can see this in both directions. For example, the study design that we used, if it is a simple descriptive study design, and what we have learned about this new study topic is just the characteristics of the study participants, and if we can't make further inference about other population characteristics and other factors, then that will be our limitation. So whenever we go up high in the pyramid of evidence generation, then it's a good thing. It can be considered as a strength of our study. If you remember, there's this pyramid, then at the bottom is case report and case series, and then cross-sectional studies, case control studies, cohort studies, RCT, and then when we go to this, these are for single studies. So RCT is the gold standard study design for a single research, because it will give us a more direct evidence of cause and effect relationship. So whenever you go high up in the pyramid, so your study design becomes more strong into generating a good evidence or sign of at least cause and effect relationship that can be taken as the strength of your study, but the reverse can be taken as the limitation of our study. But just because we have the resource and everything, we can't always do RCTs or cohorts because of their own limitation. So what's important is, for our research question, given the resource that we have, the ethical considerations, and the nature of the variables that we're studying, we should be able to use the best design available so that it can be taken as the strength of our study. For period of observation, this is for when we're conducting cohort or chart review or RCT studies. If we allow a reasonable amount of time to observe our participants so that we can observe all potential outcomes, we can observe all the natural history of the disease, then that can be considered as a good a strength of our study. For example, to see the complication of a given condition, a surgical procedure, for example, someone can make an observation for 2 weeks. If some other person conducts a research that makes an observation for up to 3 months, then this person will be able to pick both the acute and chronic complications, long-term complications. So it would be a good research. You will have a better understanding of the natural history of the condition. So, and the other is, the more variables we address in our research, it can be considered as our strength, because the true relationship, the pure relationship between two variables can be assessed when we are able to control as many confounding variables as we can. So the more variables we control in our research, the more accurate result we get in assessing the relationship between our exposure and outcome variables. So so whenever we have limited variables, it's our limitation, and when we address a lot of variables, it's our strength. The other is what there's always a bias in any form of study that's intrinsic to the study design or the way we conduct the research. So nobody expects us to eliminate bias 100%, but what we can do is we have to be able to minimize it. And what we're expected to present is there are these potential biases in our study, but we have these things to minimize our bias, the bias. So this will be taken as our strength, but if we did not handle this properly, or if some of the biases cannot be controlled by whatever design that we use due to probably ethical issues, for example, if we're studying, if we're trying to observe some surgical procedure practice, and we can't make the observation for research purpose without informing the participant. So if we inform the participant, then that participant will be prepared and will follow every procedure correctly, every infection prevention practices. So it will be like something that not that person does on a regular basis. So it will bias our result because the person knows that we're observing him and he will improve his performance. So we don't want to, even though we don't want to introduce bias, some of the things due to ethical issues cannot be eliminated. So if there are such kind of conditions, we have to acknowledge that as a limitation. So the good parts in stating our strength and limitation is not to make our paper more acceptable, but rather reporting the truth. The true strengths and the true limitation is good because every paper is known to have their own limitation. The most important thing is when we admit them, a person who uses it for evidence generation, let's say someone doing a meta-analysis, will have a clear picture of the limitation of our study. So we'll carefully assess our study and include it in further evidence generation. So there is no one to blame us. Rather, we have to be honest so that our paper can be a part of evidence in the proper way. So there are things that we should not refer to. We should not refer to when we talk about strength and limitation of our study. The first one is sample size. There is, we can see it in two ways. The first one is if the problem that we're studying is well studied, if there is no scarcity of study population, the normal procedure, the normal expected principle is to calculate sample size using the proper sample size formula, adding all statistical consideration and reaching to the proper final sample size. If we go through that process for a disease condition that's not rare, then that cannot be considered as a strength of our study. It's actually mandatory to go through that process. So for those kind of studies, we cannot present that I have, let's say our sample size calculation formula gave us 980 participants and we studied them, and we can't say that I have included 980 participants as a strength because that's actually what's expected and that's what the formula gave us. But if we're studying rare conditions and due to the rare nature of the disease condition or due to the lack of evidence in the past because of limited number of study population, and if what we know so far is like based on studies conducted on like few patients, and if we conduct similar study in a relatively larger group of population where we don't even calculate sample size and we include everyone because of the rare nature of the disease, then that can be considered as a strength because whenever our sample size increases, the precision of our result also increases. So the strength of evidence that we generate will also increase with our sample size. So we can say that since there is no prior knowledge about the problem and there is scarcity of evidence, what we studied, in our study, we have included a large number of population, which can give us a more precise result, and that can be taken as our strength. But in a normal, well-studied disease condition where there are a number of participants and where we have calculated sample size, we cannot refer that as a strength of our study. And the same goes for sampling technique. I mean, sampling technique is a choice that we make, unless there is, I don't know, when you write that as a limitation, I was trying to understand how, I mean, how you understood it. Whoever said sampling technique as a strength or limitation of study, can you please explain? Because I want to learn, I want to understand your perspective as well. But from my side, sampling technique is it's a thing that we choose. And it's also, again, mandatory process. For example, in an observation, in a quantitative research, we cannot use purposive sampling methods because it's a quantitative research are for generalization, and we have to use probability sampling method. So we can't use purposive sampling in quantitative research. So that's also not acceptable. And within the probability sampling methods, if our data allows, if our sampling frame allows, then we have to use the gold standard sampling methods, like simple random sampling method, or if not convenient, we can use systematic random sampling method. If we have different stages, we use multi-stage, cluster, and so on. So how come it can't be directly labeled as a strength of our study or limitation of our study? We have to use the proper, it's like a choice. There is nothing to blame it on. We have to use the proper sampling method from the very beginning. Even during the inception of the research, we have to plan on using the proper sampling method. So it should not be referred as a limitation or strength of our study. And the other is response rates. Again, when we calculate our sample size, we add non-response rate by considering the sensitivity of the subject matter and other factors. And this is also something mandatory and procedural, and it's not considered as a strength or limitation of study. So we should not include these things as strength or limitation of study. So I think this is all about discussion. Do you have any questions? Are you comfortable with what we have discussed so far? Okay, so if you have any question, you can drop it on the chat box. Dr. Brooke will get to it and we can discuss at the end. So when we come to conclusion, so when we present our discussion, always make sure to follow the structure. You can summarize, you can present a summary, and then interpretation of the main results in the context of what we have discussed here. And then we have to avoid these things. And finally, we have to present in the last paragraph, the strength and limitation of our study. So do not forget this. So in the conclusion of our study simply means a summary of our main findings. So here, we're not supposed to write just numbers because we have talked about the numbers on the result section, on the discussion section. Here, we'd rather present what the number means. Is it high or low, considering the available evidence and policy? And if we don't have existing evidence and policy for the study, the subject matter we're studying, for example, if it is a novel condition, then we can present the conclusion. We can give it a meaning in the context of other studies, if available. If not, then we will be forced to just present the number. For example, if you are studying COVID-19, I was a principal investigator for COVID-19 research, and there was no research in the country and even in Africa at the time. So it was very difficult to contextualize our findings in terms of what's available. So in those scenarios, we'll be forced to use the numbers, but whenever possible, give priority to give meaning for your research in terms of the available evidence and policy, or if not available, at least other comparable studies in similar setup or even in other setups. So let's say in our example, we have determined the prevalence of MI and identified associated factors. So we said 6% prevalence for MI. So here in conclusion, we're not supposed to repeat the prevalence of MI was 6%, but rather it's preferable to say prevalence of MI is high. Let's say 2% was what's known so far from different evidence. And if we find this number to be high, then we're going to say the prevalence of MI is high among the study population. And these were the factors associated with high odds of MI. So it should be presented in a sentence or two, just as a concluding remark to show the summary of our main findings. When we come to recommendation, it's important to know that there's little we can learn from one study. Whatever it is, whatever type of study design we use, however it's conducted, the number of population, whatever, it doesn't matter, because in one study, we can only learn a perspective of that studied population. We can't generalize, we can't change policy, we can't change anything. To change that, we have to look for further evidence, and we have to be able to conduct reviews. We have to be able to collect similar other research conducted in different setups during different times, and then combine the evidence, synthesize it, and look if that evidence still exists in the reviews that we have made. So at that point, we can change our practice and others. So there is little we can change based on one study. So we have to stay realistic, because if you see a recommendation paper for most master's students, it's somehow like overambitious. The study covered only few things, but the recommendations are like too much, to the level that most people recommend changing policy, changing guideline, and like even I don't know, changing treatment practice. So which is like not acceptable with a single study. With a single study, we can only learn few things. And if we find a very interesting finding, then we should be able to do systematic reviews, meta-analysis, by gathering evidence from similar setups from around the world, and synthesize and find a solid evidence based on our reviews. So for our research example, what we get are, we found that prevalence was 6%, and the important or significant factors were these three factors. So what do you recommend? Let's start with the first one. So we found that being old is associated with a higher odds of MI, or it's a higher risk of MI. So what do you recommend for this? What do you recommend for this? There are modifiable and non-modifiable factors that we can study in each research, right? For example, if poor exercise is a factor, we can say that yes, if poor exercise is great. If it is, please read the chat boxes. Interesting conversation is going on. So if it is, for example, lack of exercise, then we can say that these group of patients should start exercising, right? Some of the factors are not modifiable, like our age, our gender, other genetic factors, and others. In this scenario, what we can do is great. What we can do is we can arrange a more frequent follow-up, right? If our patients are like old, we can give them priority. We can follow them very strictly, and we can implement more strict preventive strategies so that we can prevent them from developing MI, right? For example, in COVID-19 studies, it was demonstrated that older people are at high risk of developing severe disease and dying from COVID-19. So when, due to scarcity of resources, when we get the first batch of vaccines, it was announced that people who are 65 and older, or those who are 55 and older but with comorbidity, can get the vaccine, right? This is prioritizing high-risk population. So even if we can't say them don't get old, right? So what we can do is we can give them preventive methods so that they can prevent complications. And if it, in a hospital setup, we can make their appointments more frequent so that we can pick their symptoms, early symptoms, and manage accordingly. So for DM, what we can propose is proper control of blood sugar, right? So these are the things that we can do. And again, we can say that we can recommend that this group of patients should be followed strictly too, right? So if we have just hypertensive patient, And if we have another patient with hypertension and diabetes, we can make the follow-up of the diabetic patient more frequent so that we can pick early symptoms of MI or potential risk factors. So how about for this poor diagnostic skill? Let's say the patient presented to the ER early and with potential risk factors, and symptoms were not properly identified. Thank you, right? Here we can say that if what's demonstrated is really the poor diagnostic skill of the clinician, then what we can do is provide training for the healthcare professional. I brought this example on purpose because in most research, I don't know why, I think it's a convenient recommendation. Most people write trainings when they do not find any significant factor that shows that the outcome has happened because of lack of skill in some component. So unless we get a clear indication that the outcome has happened because of a gap in knowledge or skill, we can't recommend training. So when we recommend result-driven recommendation means all you have got to do is just write down the significant factors that you obtained from your regression analysis. These are the 3 factors, but probably what we have run is like 10 or 20 factors, but we found only these 3 factors to be significant. So for these significant factors, we have to sit down and write targeted recommendations and that are realistic and applicable in our setup. So we can write that we have to follow these patients, high-risk patients, more strictly. We have to apply preventive strategies, and we have to provide trainings for healthcare professionals. So for this, to say what kind of trainings, how frequently, and other details, you can do need assessment based on a specific group of population. So the other issues, in addition to for which variables to recommend, what we can do is our recommendation can be targeted towards the institution or organization who can intervene. So who can intervene in this research and can bring change. So don't be like realistic again, because sometimes there's a trend of classifying our recommendation. We usually put it as clinician, regional health bureau, Ministry of Health, sometimes WHO. So regional health bureau, Ministry of Health. I mean, if the study that we have conducted is among study population who are on follow-up within these institutions which are like led by these bureaus, then yes, they might use our input to change their practice. I mean, to guide their practice. Otherwise, we have to stay realistic. And the other thing is, in any publication, in any journal, there is no recommendation section, because a recommendation is like, it's very difficult to recommend based on a single study, as we said. And what you can do is you can add your recommendation as part of your conclusion. So what we can say in our study is the prevalence of MI is high among the study population, and old age, DM, and poor diagnostic skills were found to be associated with high odds of MI. Therefore, we recommend a more strict follow-up for these high-risk patients and providing trainings for healthcare professionals. So we don't even present it as a separate section by indicating all the stakeholders who should take part in the implementation of the research. We have to be careful as a student research. We're expected to write these things, but in publication recommendation, too far recommendation is not acceptable. And some even don't allow you to write any sort of recommendation, even as part of the conclusion. So we should be careful while recommending our article.